everyone. It is nice to meet you after a year, and I'm really happy to present my article in front of this collection of guests. My research topic is on incidence and predictors of early mortality among trauma patients visiting West Amhara region referral hospitals. I'm the PI and have colleagues who were engaged in this study. And the study was done in 2024. Okay. Here are the presentation of slides, introduction, objective, methods, result and discussion, conclusion, recommendation, and finally the acknowledgement. So, as an introduction, traumatic injury is a major global public health problem, and over 90% of trauma-related deaths occur in low and middle-income countries, including Ethiopia. And early deaths, especially within hours, remain largely unchanged despite advancements in the emergency healthcare system. And as we all know, trauma deaths have been following a triangular pattern: immediate, early, and late deaths. And the first 60 minutes, known as the golden hour, critical for survival. And the preventive deaths are especially common during this early phase. And Ethiopia needs a significant trauma burden with limited hospital care system. And recently, especially in the past 3 to 5 years, conflict-related injuries contributed substantially to mortality, and limited evidence exists on early trauma mortality in these conflict-affected areas. Here are the objectives to determine the incidence and predictors. Specific objectives are to determine incidence rate and to identify the contributing factors. The methods, prospective cohort study was conducted from March to August 2024 and conducted in 3 referral hospitals in West Amhara region: Debre Marcos Comprehensive Specialized Hospital, Talabagalon Teaching Specialized Hospital, and Talabagalon Specialized Hospital, where studies settings. And these hospitals particularly were providing care during the active armed conflict time. And all trauma patients present interned during this 6 months period were included in the study, and the sample size constituted 531, and finally 518 samples were analyzed, and consecutive sampling technique were used by assuming that trauma victims present to the ED at random. A structured questionnaire and checklist were used, and the primary outcome were early mortality, which were operationalized as trauma-related mortality within the first 24 hours following the incident of trauma, and variables including socio-demographic, clinical, and injury-related variables, and related variables were also used and were assessed whether they predict early mortality or not. Descriptive stats and person time incidence rates were reported. Kaplan made survival analysis and log-rank tests were used. There was also cost proportional hazard regression analysis. And when we come to the result and discussion, the mean age of the study participants were 33.5 years, and 75% of injury victims were males. Majorities injured were economically productive age group. This trauma were affected uh, younger population, and there was also low ambulance usage rates, which was only 15.8 of the victims were presented to the AD with ambulances. So this indicates weak emergency medical service system in the area. And blunt injuries and penetrating injuries predominated. And unfortunately, about 27% of the injured victims were related to gunshot. This was really unfortunate for the victims. Head injury and polytrauma were common predictors of severity, and early mortality rate were about 12.7%. The overall incidence rates were 15.26 women per 1,000 person hours. And this result were higher than reports from higher income countries, like a study reported by Ralph. And this high rate is likely driven by delayed presentation, limited hospital care, and conflict-related injuries. The majority of this occurs in the first 24 hours, and this highlights persistent gaps in early trauma care delivery. And the mortality rate increases sharply after 12 hours, deviating from classical trimodal distribution, that is the majority of the deaths are within the first 1 hour, contrasts with declining net mortality in high resource settings, and this may reflect delayed definitive care and limited ICU capacity. And this may also be related to secondary complications contributing to less early deaths. And this may indicate that there is a need for sustained monitoring beyond the golden hour of the first 1 hour. And this is a Kaplan-Meier curve showing the probability of death or the death rate. And here are the Cox regression table, as you can see. Females, those present with ambulance and abnormal diastolic blood pressure, and those with severe to moderate GCS score indicating severe to moderate brain injuries were reported as contributors or predictors of early mortality. So females have significant higher early mortality hazard. Similar findings reported in some European and African studies as reported by Punchak. And this may relate to delayed care seeking and social-cultural barriers, possible difference in injury patterns between males and females, and indicates for this might indicate for gender-sensitive trauma care approaches as well. And the other is the one that we already know, the traditional predictors, the abnormal diastolic blood pressure were predictor, consistent with studies linking hemodynamic instability to trauma death, was reported by Kuwait, Europe, and Ilmus. And low diastolic blood pressure suggests hemorrhagic shock, and high diastolic blood pressure may reflect traumatic brain injury related stress that may result in early death. So this all indicates several physiological arrangement and supports early aggressive monitoring of and resuscitation protocols. This is a Kaplan-Meier curve with log rank test indicating the diastolic blood pressure predictors. The other, moderate to severe GCS score, were the strongest predictor of early mortality. This is also established in textbooks and other teaching materials we already use. aligns with global evidences, and SAVER GCS reflects compromised airway breathing and cerebral perfusion, and limited neurosurgical capacity may worsen the outcomes, and this reinforces GCS as a key triage and referral decision tool. This is also the Kaplan-Meier-Lewis log test indicating the predictors. Okay. The other thing, ambulance survival were associated with high hazard ratio. That means those present with ambulance were more likely to die, but this likely reflects high injury severity rather than transportation risk. Ambulance by exertional loads be associated with early deaths. However, as we all know, those who were transported with ambulances might be those with critical condition or severe injury. So this highlights urgent need to strengthen pre-hospital care stabilization and emergency service capacity. So, as a conclusion, early trauma mortality remains high, and physiological stability and severe brain injury are key drivers of mortality, and there are also system gaps. So, recommendation for clinicians, early identification and management of hypotension and low disease is highly recommended. Also, it is already known, and those who are concerned with health system are required to strengthen hospital and referral stabilization capacity, as well as improve emergency medical service coordination in conflict-affected regions. So, acknowledgement, the Marcos University is acknowledged for funding this research. The study participants are also data collectors are acknowledged, hospital administrators, and ISAP is also, we want to thank ISAP for providing the chance to present our finding for scientific dialogue. Thank you.
Thank you, Mr. Mister, for your very nice presentation. So we are taking 5 more minutes from the allocated time. I hope that our presenters will strictly adhere to the time allocated. So next up is thanks to Abebe. He's currently a lecturer at the Marcos University, and he has master's degree in emergency medicine and prescribed care nursing from the University of Condor in 2022, and he has more than 40 peer-reviewed articles which are published in reputable journals. So he will present his research article on emergency medical service utilization in Northwest Ethiopia.
Okay, thank you, the moderator. Thank you, the audience, and thank you, the ISEP, to provide the chance to present our work in this scientific conference. Here is the title and the co-authors, fortunately, of the co-authors of this paper is here. These are the presentation outlines. I will not go through the details of each section for the sake of time. As you know that emergency medical service is an integrated service that provides primary on-site medical emergency care and urgent transportation from the same to the nearest facility and ongoing care during transportation. So when the emergency medical service is an integrated service that incorporates these components, and we can prevent 45% of this and 35% of disability by providing an integrated emergency medical service. In Ethiopia, people have been facing high burden of road traffic accidents, acute illness, and increasing the burden of non-COVID care diseases and there are lots of injuries due to the presence of armed conflict in different regions of the country. Emergency medical service in Ethiopia there is a growing government concern and many interventional efforts by Minister of Health, but unfortunately it is still a net need of the community. And the standard of emergency medical service is limited to transportation by ambulance only. And according to different studies conducted in Ethiopia, the service utilization is ranging from 5 to 39.7. And different factors that hinder this service utilization. The burden of accidental injuries and the interruption in transportation in Amara due to the presence of armed conflict in the past 2.5 years established the need for emergency medical service. Here is a general objective to determine the practice, the barriers, the possible solutions, and the factors associated with emergency medical service in utilization in Northwest Ethiopia. When I came to the methods, it is multi-center, institutional-based, cross-sectional study design using a mixed sequential explanatory approach, and the study of the source population is patients presented to the emergency department in third care for quantitative study, and those healthcare providers working in the emergency department and health officers working in the Oregon's office, as well as the zonal health department where the source and said population for the qualitative study. And here is the sample size for quantitative 449 and for qualitative 25. The purpose of sampling to qualitative study and the systematic and simple random sampling for quantitative study were applied to select the study participants. Interviewer Mr. Questioner for quantitative and engaged interviewer trained for quantitative were employed for qualitative study. Here is a sampling procedure. There are 11 public hospitals in Northwest Ethiopia, particularly in the East Gonja. Among these, 5 were selected using the simple random sampling. And after proportional allocation of study participants for some size to each hospital, systematic random sampling was applied to select study participants from each hospital. The previous trained supervision and triangulation as well as audit trials were employed to ensure the quality of data, and data were collected using overlaid software that exported from SACAM. And logistic regression was employed to afford quantitative data, and thematic analysis was employed, and triangulation of quantitative and qualitative data was done. A total of 428 study participants included with a response rate of 95.3, and for your surprise, around 6.6% of the study participants used emergency medical service, and this was lower than the study in Addis, in Jimma, Southwest Ethiopia, and Tigray. And the reason maybe due to the difference in the availability of infrastructure, awareness of the community, as well as the availability of private hospital. The orders of emergency medical service utilization were 2.7 times higher than participants who knew the ambulance call number as compared to their counterparts. Therefore, improving infrastructure, increasing community awareness, and then promoting the availability of ambulance are crucial or essential. Those study participants with trial score of greater than the course 9.8 times higher odds of using emergency medical service as compared to those with low trial scores. This is the fact due to the fact that patients with higher trial scores indicate more urgent or life-threatening conditions requiring immediate medical intervention. And the odds of using emergency medical service among participants who had previous experience were 3 times higher as compared with their counterparts, due to the reasons that previous users of ambulance or emergency medical service may feel more confident in calling for ambulance because they are familiar with the service. Participants who presented in the emergency department during the night time had 6.6 times higher odds of using emergency medical service as compared to their counterparts. This might be due to the emergency occurring at night, often perceived as more urgent, and individuals may more likely to use ambulances because there is no option to use commercial vehicles to transport to the nearby facility. The qualitative findings were thematized into 3 major themes. The first one is the unavailability of ambulance or lack of ambulance, the communication-related barriers and the conflict-related barriers. As one of the interviews said that lots of ambulances are owned by groups and the unvetted ambulance cannot conflict between operators, carriers, and global centers was stopped due to the fear of violence and attacks. Therefore, resolving the conflict is the key solution to overcome the problem. And the other, I don't think ambulances are doing their primary tasks. They are providing service for government officials, their service for transporting wounded and poor. So as a conclusion, the utilization of emergency medical service is low. I can say that this is the most underutilized service in the health among the healthcare service. Knowing that we are number presenting to the aid at night priorities of emergency medical service and higher factors that significantly associated with the utilization. And the barriers are the presence of armed conflict, poor community awareness, and availability of infrastructure, and delayed response from ambulance and lack of ambulance vehicles. Unfortunately, there is no knowledgeable number in the region, no trained community responders in the regional level, and no paramedics are working there. So these are the barriers for utilization. For recommendation, data to increase community awareness and data to operate the ambulance station as facilities in order to ease their access and to minimize their response time, and resolving the conflict, improving community awareness, and coordination of available resources are the positive solutions to improve emergency medical utilization and further studies needed to assess awareness. And thank you for your patience. People do not arrive late by chance, they arrive late because emergency medical services are underutilized. Thank you very much.
Thank you, Mr. Mangustu. We will have one more presentation before opening the discussion table. Our next presenter is Session Setting Ami, is a health professional, academician, programmer in Bulgaria. Most of us coming from Telegram. Is a group, is very active, is employed at the Juma University School of Nursing, is assistant professor and currently a PhD candidate in evidence-based care, healthcare. He has more than 20 publications and more than 15 global articles in national and international topics. He is a founder of Brady Program, systematic review and analysis evidence synthesis platform, and he is also an editor
Chief Editor at Insider.com. His research title is Mitigating Political Bias in Sparse Data Meta-Analysis, the Design and Implementation of OIPCO, an accessible evidence synthesis platform. Welcome, Mr. Shmuel.
Thank you for giving me this opportunity. I'm proud to have you. Something will start. Basically, when we active this conference, as the title of this presentation is mitigating the political sparse data analysis and the design and implementation of Hub and accessibility in this platform. So it's very difficult if you want to rush just try to finish it. And say so this outline of the presentation. As most of you know, the system use here. The kind of systematic uses started in the 18th century. The data analysis joined the systematic review since 1970. Yes, currently we size is the hierarchy, the top hierarchy known for the source of the knowledge, the subconscious guiding development, and condition development of decision making. Softwares are just becoming integral parts of the systematic review since just 2002 because of the advent growth of the literature, systematic initiatives from the manual to digitalized platforms. It also shaping how the results are interpreted. So this is the core theme of this project. So here, software, as most of you know, as you know, is a black box. We don't know what's the reason behind at the back when our analysis. But those topics really affect the output of the results and even also the decision. So until today, we know that the default sequence of the software decides on behalf of us. It's not us who decides which kinds of analytical methods we are going to use for the results. So, especially when our data is passed, we just there are methods that we have seen the current software even extends to the new. So, the software also lacks scientifically detailed solutions. These are just scientific standard criteria used to analyze the known systematic analysis software. As we know, none of the softwares fulfill the criteria. But I think the two pillars, this one is the pillar, and this one, pillar. These are good software which we have 27 exactly standard features. So, of the top 7 feature platforms, 6 require subscription. This one almost low. So, first, for sites from income category, almost things are inaccessible. There are also, besides the huge problem, there are other data which are used to conduct the analysis, but it's difficult to use the software. Here, there are two workaround solutions. One is physical communication. We have sometimes the organization of data and analyze. The other is excluding of something studies zero. Zero outcome studies with regular studies filter, especially safety and where to do the study, advancement. These are also common. Just you may find papers with zero outcome, but that means it will have, it does not mean it will have scientific computation. Even there are certain times where they don't have very huge waste in medical science, for example, bacterial infection. Saying this, these softwares just user-friendly, but basically our problem. The new or the statistical package is programming skills. So we need a kind of software that need understand our data. That's why we develop with ProHub, which detect in our units of algorithm. Our objective of research is just divided to an extent to which such can be represented. And another one is whether it is possible to design and implement a comprehensive systematic review analysis software. This is the kind of design we use review literature, quantitative validation, images, study of this design to analyze user acceptability tests. So we plan to involve around 7 to 10 new researchers, but I think around 40 for more researchers participated from different universities, and also we are participating in this study. Conducted user acceptability test. So, unlike other systematic review softwares, these have one additional feature, which is a dual pillar feature. The project manager project manager will plan, design, and manage the project, look in terms of the finance reports, every manager has this discussion forum. All things are here. The other systematic review team will be conduct systematic reviews. So we use this kind of technology. I myself, as a lead developer, who produce this program. It looks like this one. We have a planning stage, production stage, reporting stage, just project administration and organization having. So we have a few stuff, so we don't have enough time. But this is just how to design it. This is just the analysis mechanism. If you have a quantitative analysis or quantitative descriptive analysis, we have data analysis of effectiveness in proportion and continuous outcomes. We have also fixed and random effect, as linear model, and we have advanced analysis like subgroup analysis with direct vision and the analysis. And we have also little bit meta analysis plus umbrella review. Is just how the analysis plan looks like. Then we have also user identity synthesis problem, which is just a cohort of this project, which you have around 6 analyzed. Previously, we find one you will never find all these analytical methods in this episode. Well, we have four stage. We have four two stage. One, two one stage like this. This one is the validation. This method found superior than the other methods. So let me go to the examples. This is just the feature analysis. It almost fulfilled 7.6 criteria expected from systematic review platforms, and now softwares now fulfills such standards in the world. So the other one is how the feature looks like. For example, this is just when we construct a research patient, and just the AI we use to construct research analysis, and we just move this query here and just conduct research in the databases. And it has currently two active non-scientific database research, and soon Sri data based. This is just how it will be researches. This will be summarized, refine your research strategy. You don't have to go to the database process. This will be considered every week. This is just how the contact is taken today. This is, for example, screening dashboard. In this screening dashboard, we have AI assistant. The AI assistant will read the abstract and provide you the AI, and this will include decide like this, or you may accept the AI decision. The other one is just how the analysis outcome looks like. This is just the first plot, and this is just I think is the methodological feedback to the result interpretation, the analytical method you use to do the analysis. This is AI generated. This is automatically constructed. Prisma flowchart. This is just automatic report generation templates. You create automatic report and generate your reports. It has also automatic manuscript generation. It generate manuscripts for you. This is a validation result. As you know, it just perfectly matches with expected scientific standards. This is just for mean difference, standard mean difference, validation basis. This is just a standard data set test for full rebalance. And this even this it handles challenging data sets. Full rebalance. Our first objective was just to validate this basis from where we are happening. For the sake of time, yes, we have these participants from the international institution. We use as certificates. This is the question, the average score qualification. We use for question. Just also feedback. Just for example, this is one feedback provided by one participant. The other one is just currently, as of today, we have around 140 users. That is, we reach around 40 plus children higher education institution from other African countries and from international from other countries. We will about the 29 users from 10 plus institution evaluation. We established collaboration with Zambia, and we are securing academy. We also secured IP certificate. This is concluded. We are access it here. It's free for everybody. You can show these are the differences. So I would like to acknowledge supervisors who supervise this issue here. And leaders to talk available and who provide us with the answers for databases. Participants of the study will check for this opportunity to continue support of the development in my university. And those all who provide support to this project, they will.
Thank you, Mr.